Hello, everyone, and welcome to HeadWise, the weekly video and audio podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine beginning at the age of 4. Please remember to subscribe to our YouTube channel if you're not there already. I am excited to be here today with Dr. Frederick Godley. Hello, Dr. Godley. How are you?
Hello, Lindsay.
So Dr. Godley is an otolaryngologist and the president of the Association of Migraine Disorders. He's also just one of the kindest people I know. He's super fun to talk to, and I think you're going to love him as a guest. He is here today because our topic is something called sinus migraine. Dr. Godley has been publishing on this recently, and I'm fascinated by this topic. The reason it caught my attention is my father and I both developed chronic migraine when we were in preschool. But we were both told that we had sinus headaches. I wasn't diagnosed with migraine until I was 17, and someone gave me an Imitrex injection and said, oh, this might be migraine. But to be honest, my father still has all these very interesting sinus-like symptoms that come along with his migraine. And so when Dr. Godley started talking about and writing about this, I was listening very closely and found this very interesting, this interconnection between these two topics. Dr. Godley has published a hypothesis that a migraine variant may cause sinus headache symptoms. This has been termed sinus migraine. I can't wait to hear what he has to tell us, and I think everyone's going to find it very interesting. So, Dr. Godley, just before we get started, can you tell our audience a little bit about yourself and why you work so hard in this field?
First of all, Lindsay, thank you very much for even broaching this subject, because it's a murky area. It's not well defined yet.
Right.
But as a general otolaryngologist, I was treating a number of patients who had sinus disease or symptoms and thought they had sinusitis, as did the clinicians treating them. But when they came to me, I had the ability to get a CT scan of their sinuses, and often the CT scans were normal. So there needed to be some kind of an explanation for why they were having the symptoms they were having. Subsequently, I have had to learn a lot about migraine disease, and along the way, this concept that migraine, which is a hypersensitivity disorder of the sensory system, could well be creating a lot of these symptoms. And I've just been motivated to share that experience with people and advocate around this topic. And I will tell you later in the discussion some of the ripple effect that this is now having.
Okay. So let's go ahead and talk about what this is. Now, I think since you brought it up, I'll go ahead and ask this question first so everyone is clear. Is sinus migraine currently an official headache diagnosis?
No, it really, I think most headache specialists would just consider it a variant of a headache. The issue for me is that that may work for a headache specialist, but most of these patients are in fact seeing primary care physicians or otolaryngologists who are less well versed with the more, let's say, relaxed definition of a headache. And so when these patients present, they don't have traditional headache symptoms and therefore get misdiagnosed. And the consequences of that are great.
Okay. All right. So I think many people in our audience who experience migraine are probably familiar with the fact that a severe cold, especially one that leads to a sinus infection, et cetera, can trigger migraine and leave us pretty miserable. But that's not what we're talking about here. We're sort of talking about the opposite. We're talking about a migraine variant that could work in the other direction. The thought is that perhaps there could be a type of migraine that causes us to have sinus symptoms. So can you, we will get to the pathophysiology behind it, the reason behind it. But first, can you explain what a patient with what is termed sinus migraine might actually experience?
I will. Let me just also mention that the kind of scenario you mentioned at first, where a patient has a cold and subsequently a bacterial or even a viral infection, triggering a headache is a known phenomenon. And there are international classification of headache disorder. The third version of it does have a classification system for that type of headache with criteria. The issue is that that makes up only a very small portion of the patients who present. So usually patients say, Dr. Godley, I've had this recurring sinus infection and my medications just don't seem to have lasting effect. Can you help me? And so I have usually begin with a suspicion that I want to make sure that this is not a neurologically generated symptom rather than a bacterial or viral infection. So the problem is that patients come and they'll complain that they have facial pain or pressure, and it's across their sinuses. So we did a survey of 1,630 patients or participants over a 4-month period. And these were patients who came from the migraine community and asked them a series of questions about their sinus symptoms. And what they revealed was that over 90% of them complain of pain and pressure across their forehead and behind their eyes. So it's usually the upper half of the face. The number of people who complain of dental pain or cheek pain is closer to 60%. And interestingly enough, they also complain equally of ear pressure at the same time. The other factor is that the specifics of whether it's pain or pressure is almost equal. Most people will have both sensations, with only a small portion, about 10%, will have either just pain or just pressure. So it's usually a mixture of those two symptoms. The other factor is that it is usually bilateral. The majority of them, it's both sides. And that is roughly 60 or 65% of them will be bilateral. And
that means two sides of the face, as opposed to, often when we talk about migraine, just so everyone is aware, we are often talking about just one side of the face or head. So
yes,
go ahead.
Yes, and I mention this because migraine headaches are often characterized as unilateral, but this tends to be really across the face in various locations. And in fact, the number of people who have both a headache and these pressure lockstep together is very small. Only about a quarter of the respondents have both a headache and facial pain and pressure at the same time. Now, sometimes they'll have a headache, but more often in asking patients about this, they have a distant history of more migraine headaches than they do now. And now the symptoms are more heavily on facial pain and pressure. So there seems to be an evolution of this. An interesting factor in this is that the recipients here of the questionnaire were almost all women. It was about 87% of women. And so just as migraine disease is in general very gender specific, so are these symptoms.
Okay. So you spoke of, now this is something that I am just curious about, because you spoke of pressure and pain-like symptoms. A lot of us are aware that we can get with migraine autonomic symptoms where our nose might run or our eye might get watery, things like that. Do these people get runny nose symptoms, congestion or nasal drip or anything like that with these things that we would probably feel like were sinus symptoms?
Yeah, absolutely. And this is what makes it, even more devilishly difficult to distinguish between an infection or not, is that about 60% of these patients were also getting nasal congestion and runny nose. And then when we ask specifically what's the secretions like, as one might expect, it's most of them have a clear, runny, thin kind of secretions versus a really thick and discolored. And the reasons for this are that the autonomic system also is generated from nucleus. Well, maybe this going into pathophysiology, but there is nucleuses in the brainstem which are controlling the autonomic, or the part of your nervous system you're not thinking about, like digesting, and they're controlling through nerves the size of blood vessels. And inside your nose, you have things called turbinates, and those turbinates are what gets stuffy when you get a cold. And that stuffiness comes from those small blood vessels swelling and filling up, and that makes the nose feel stuffy. And it can be controlled by the autonomic system, which can be part of a migraine condition. In the same way, the secretory cells, just like think about, we sweat and we don't think about sweating, it just happens. That's because it's also controlled by our autonomic system. And inside the nose, you have two types of secretory cells. One are serous or thin secretions, and the other is mucoid and thicker. So when you have a dysautonomia or malfunctioning of the autonomic system, you can have either really thin, watery secretions or thick, but they're usually clear, might be a little cloudy, but you can reproduce a lot of the symptoms that you would normally use to diagnose a rhinosinusitis.
Okay, that was actually a very interesting explanation of what's going on in the turbinates and everything. I've never heard anyone explain it that way, so I found that very interesting. Let's see. So we talked a little bit about the pathophysiology. Would you like to continue more on the pathophysiology, or should we talk about some of the signs? Let's go ahead and finish up the pathophysiology of the sinus migraine. I think that everyone might find that very interesting.
So the pathophysiology is still not clear. So we really can just look at what other types of migraine are like this. And one can look at ocular migraines. So your eye is, functioning perfectly normally, and then suddenly you start to get either sparks of light or distortions of vision, or even parts of the vision that stop working temporarily. So that's a form really of one could think of as a hallucination, just in the same way as you can, as migraine people complain, sometimes they can smell very rotten smells that nobody else does. And that is that somehow from activities, probably in the brainstem, there are these spontaneous firings of these special sensory organs and creating illusions. And if one understands that this could happen to other parts of the nervous system, then it gets easier to explain what's happening, for instance, in vestibular migraine, where you have a set of nerves that are controlling, your sense of balance. And if they start malfunctioning, you get these very odd forms of dizziness, which is vestibular migraine. Patients can have this happen also with parts of the trigeminal system, I would argue. And the difference between this and a headache are twofold. One is that the sensors in the sinus mucosa are probably different than the ones in, let's say, the meninges, or where we think that a lot of the pain signals are generated for a traditional headache, but rather these are mechanical type of receptors. So they measure pressure. And so if they fire spontaneously, it feels more like pressure, either in the ear or the sinuses, rather than pain sometimes. So that may explain why patients and clinicians get confused by this.
Wow. Okay. All right. So this, and I'm trying to make sure, like, I'm trying to think, like, if I'm someone listening to this for the first time, how does that lead to, I think that's a hard jump for someone's brain to make. How does that lead to a runny nose?
Okay, so let's go back and
or congestion.
talk a little bit more about, where is this coming from, this hallucinations and all? Well,
right.
Again, the pathophysiology that we know of is based on sort of two concepts. One is that you have cortical spreading depressions, which are attacks that are generated from the central nervous system,
right,
that activate our pain sensing systems and give us headaches for reasons that are, otherwise, unknown. I mean, there can be triggers, but you can still get a headache without necessarily a trigger. And that whole, even the trigger concept is sort of being re-examined now. But those cortical spreading depressions usually are marked by an event that passes within 3 days. It goes through different phases, but it's generally contained in a relatively short period of time. Then there's this concept that over time, through processes which are still being debated, you can develop a chronic form of migraine or attacks, but also things like allodynia, where your sensory system to your skin becomes hyperactivated, and now just brushing your hair, wearing jewelry, collars on your shirt are irritating because they're hypersensitized. And so from that is this concept of central sensitization, which just would suggest that there's a neuroplastic change to the nerves that make them maybe change their threshold of activity, but they're firing more spontaneously or something to that order. We don't really know completely, but this,
basically something that shouldn't hurt starts to hurt.
Right. But the other way to think of it is that our nervous system is just not functioning the way that it should be.
Right.
And so it's active when it shouldn't be. One way that most people could relate to this is tinnitus or tinnitus. And many, many people experience this. Well, that's basically in your auditory system, you have a part of that system which is now malfunctioning, and it's not dangerous, but it's very annoying because it's producing a sound all the time, which without being triggered or anything. So we know that actually migraine can cause tinnitus. So this is, again, sort of what you have to hold on to as potentially an explanation for why you can have the feeling that you have sinusitis when in fact you don't have an infection. So I would just segue into that and saying, why is this so important? Well, the fact of the matter is that rhinosinusitis is one of the most common medical conditions that we see in offices across the country. It affects 15% of the population every year. So it is comparable to migraine headaches, which affect some number of the population similar to that. It also, rhinosinusitis, it has its own disability. It's been estimated at 73 million days of productivity and activities are lost every year to rhinosinusitis. There's a cost to our medical system of $2.4 billion of direct costs every year to treating rhinosinusitis. And it is one of the most common uses of prescription antibiotics.
Right.
So over 80% of people who have complaints of rhinosinusitis receive antibiotics. So why is this? The American Academy of Otolaryngology, which is my academy, has developed clinical guidelines. And those guidelines instruct not only otolaryngologists, but primary care physicians in what should you do when these patients come to you. And the criteria is that if a patient has facial pain or pressure, combined with nasal congestion and a nasal discharge, and by that they mean really a purulent discharge.
So that means pus. That means pus,
yes,
correct?
Thank
okay.
you.
Just letting everyone know.
Sort of the white and discolored and yucky tasting stuff, which would come from actually the white blood cells, but it doesn't matter. But it comes from an infection. It could be viral or it can be bacterial. But those are the criteria. And actually, you know, we suggest that people hold off for a week to see if it'll resolve spontaneously, because many times this is viral and it will go away. And then it suggests that you use oral antibiotics. You wait a week. If the symptoms are still there, you should prescribe a second course of oral antibiotics. If after 2 to 3 weeks of this, a patient still is complaining of sinus symptoms, then it recommends that you do endoscopy or CT scan and consider other etiologies for those infections.
So other causes, other things that could be wrong.
So all well and good, but now you have patients who might have what I'll term sinus migraine, let's say a migraine variant, in which has symptoms of facial pain and pressure, nasal congestion, and rhinorrhea, which rhinorrhea is a word that means just that you're producing excessive secretions. And most clinicians and patients aren't really differentiating between pussy discharge and just natural increase in the discharge because of dysautonomia. You see that you've basically mimicked the presentation of a bacterial infection. The consequence of this is that, as I said before, 82% of these people, it's been estimated, are getting antibiotics. And we have a problem with a stewardship or controlling the misuse of antibiotics, because it's leading to higher resistance and more ineffective use. The efficacy of the antibiotics is lessened. Not to mention that there are some serious consequences from using antibiotics, such as changes in the microbiome, the worst of which is getting C. difficile, which actually can kill people because through excessive loss of diarrhea. And so this has effects, going to this in great length because the point is that there's a lot of people who are being misdiagnosed and mistreated because we haven't differentiated the, let's say, infectious form of sinus symptomatology from neurogenic, or our nerves are creating this illusion.
Okay, so I was a lot more quiet than I usually am because I didn't want to interrupt the, it is an interesting clinical story to tell. The pathophysiology is very interesting. And I think many of our patients are sophisticated enough because we talk about migraine so much to understand that. I hope I interjected enough and tried to define some of the more clinical words, but what I want to say now is, so let's say that we have someone listening that says, wow, I am one of these people who it seems like I've had a sinus infection forever. It does have these features that Dr. Godley is speaking of. What are some of the tests or signs that perhaps it's more migraine-like than sinus-like? Are there going to be some signs that this person might notice?
So from my personal experience, what I often will do is to get a CT scan of these patients.
Okay.
And usually I'm really interested in getting that CT scan when they're symptomatic.
Okay.
So over 50% of people who have a CT scan when they think they're having a sinus infection will have normal, clear, healthy sinuses. That's been documented in a couple of different studies. That certainly was the findings we had also with our survey. But the other aspect of it, the other 45% of people will have some findings in the on their CT scan, but those often don't correlate well at all with the symptoms. So they may find a polyp, or they may see a retention cyst, or they see a little pocket of where there's inflammation in some of the sinuses. But there have been studies to show that those usually correlate very poorly with the symptoms of what the patient's complaining of for pain, and where the pain and pressure is. And so the CT scan will help me occasionally identify somebody who really has an infection, but in many cases, it's a teaching tool for me to help my patients understand. When I go over the films with them, I can point out that they really don't have anything that's happening out of their view because they can't see their sinuses. So I'm allowing them to look in their sinuses and see that they really are healthy and that there's something else going on. Because, you know, as a patient, you need to some convincing that this is not a crazy idea. With that being said, when I'm trying to identify these patients, I'm often get early hints because there's a constellation of other symptoms. If you think about the way we diagnose migraine headaches, is that we're looking for a headache combined with light or noise sensitivity or GI symptoms. And if you think about that, that means that other parts of your nervous system are involved with whatever this is. It's not just from muscles of, let's say, a tension headache. It's actually generated more from your nervous system. In the same way, when I'm interviewing patients about sinusitis, I'm asking questions about light and noise sensitivity and ear symptoms. A lot of patients, if you ask them about it, have these odd pressure feelings, popping and crackling, hypersensitivity to touch around their ears, sensation that they have water in their ears. So there are other parts of the sensory system that are also misbehaving that give you an idea that this is affecting also their sinuses. And our survey, again, underscored that this is real, because about 87% of patients complain of light or noise sensitivity without having a headache.
Okay.
So headache is not as important a criteria in making this diagnosis, because of the headaches actually are often receding at this point in their life. So instead, I am usually asking about a distant history of headaches. And most of these patients have had some kind of a history of migraine headaches in the past.
Okay, so a lot of people, and again, this is not a diagnosis that we can really find in the books right now, but this is something that Dr. Godley has published on. But a lot of people who present that seem to fall into this category had a history of migraine, and now they have something that seems to feel like and present like more of a sinus infection or sinus headache. But they may still have some of these features that we look for in migraine, like the photophobia, light hurts their eyes, or they don't like loud sounds, etc. Correct?
Yes, and I think the other thing is that just like with traditional migraine disease, there are a lot of comorbid diseases. So because this is a chronic form of migraine, chronic forms of migraine have a very high rate of other chronic diseases that are probably maybe genetically linked. And the big four would be fibromyalgia, sleep disorders, of which insomnia is usually the leading one. And they're going to have gastrointestinal symptoms. And let's see, what would be the fourth one? Would be dizziness.
Right.
So when we did our survey, 96% of these patients who had rhinosinusitis symptoms that were likely migraine related also had some form of dizziness. Okay.
So then let's say you do determine that you feel there may be a neurological component when you are talking to a patient who has some of these sinus type symptoms when they present. What do you do to treat them when it looks like it could be sinus migraine?
So the beauty of this is that because it is a chronic form of migraine in most cases, and again, I just would emphasize that when we asked how long do the symptoms last, only a small minority of people had symptoms that were less than 4 hours long, and the vast majority of them were 5 days to a month in length. And some people, about more than 5% of patients had 6 months of continuous symptoms. So again, reinforcing these are chronic. Therefore, they potentially would respond to preventive medications. And indeed, in the years that I've been treating this, they do, in fact, respond quite well to the same preventive medications one would use for chronic headaches. Again, we don't have any specific diagnostic criteria, nor do we have any way to personalize the medicine. So the choice of those preventive medicines is much the same as the choices you would make for treating, a traditional migraine headache.
Okay. Now, out of curiosity, how common do you think this problem is? There's so many people that are diagnosed with rhinosinusitis, et cetera. So how common do you think the actual problem of sinus migraine could be?
That is to be determined, but there are some signs from previous studies, small clinical studies that have been done to suggest that about 60 to 80% of patients who look like they might have a neurologically based form of rhinosinusitis will respond to various forms of migraine medication.
Okay.
So let me just say that again. You're talking about not just a small portion of this large number of people presenting with rhinosinusitis, but it might be 75, 3 out of 4 that are actually sinus migraine, not bacterial infections. So this really needs to be evaluated better and codified better to change the clinical guidelines that we currently have.
Okay. So if someone, after listening to this, feels they could be experiencing sinus migraine, what should they do?
Well, at the moment, it's a little hit or miss because this is still a condition that is without a name. It is without specific criteria. It is not mainstream medicine right now. So one probably is best off finding either a headache specialist who can understand that this is a possibility, and I think many headache specialists do. I don't think that most neurologists would probably be savvy about this being a possibility. And speaking for otolaryngologists, there are a number of other people like myself who have come to the same conclusion. And therefore, I no longer have to feel like I'm a complete renegade here. I'll tell you that we have a group that has been meeting in our academy for the past 3 years and are very concerned about this and are trying to forge a broader understanding. And so we've in fact just formed something called the Migraine in Otolaryngology Society.
Oh, wow, okay.
And I go into this because we are just about to launch a website, which one could find through Googling that name. And in there will be a listing of its members. And of those members, there will be people, clinicians who are particularly adept at vestibular migraine or the dizziness that's caused by migraine. And there'll be rhinologists, people who are more concentrated on sinuses, who will be familiar with this concept and treatment. And so I hope that that will soon become a resource for patients to be able to identify who these clinicians are and see if any of them are close to them so that they can get somebody who will, work through the process of feeling better. The encouraging thing is that I've done some surveys in my office, and for instance, the monoclonal antibodies, which are used for treating migraine headaches, have almost equal efficacy for relieving sinus pressure.
Wow.
So anyway, I will circle around on that idea in a minute because I think you have a few more questions for me.
Well, you've answered so many of my questions. I've been a lot more quiet than I normally am because you were really on a great roll, and I didn't want to interrupt. And I was going to ask if you had any recommendations for clinicians who were listening and wanted to learn more. So can you repeat the name of the society that's going to have the website in case they didn't quite get it?
Sure. So this is Migraine in Otolaryngology Society.
Okay.
For clinicians, there are other resources that are now existing that they might want to take advantage of. There are learning opportunities through organizations like the National Headache Foundation, in getting the basics of how to treat migraine, which will be helpful. But in our organization, we are very proud of the online course that is available at mycme. I think that's .org or .com, it might be .com. And in there is a free CME credited course that will help you learn how to treat migraine. In addition, we support a website that helps clinicians stay up to speed on research items, and that's the Migraine Science Collaborative. So those are resources more for clinicians more than patients.
Okay. Is there anything else you'd like to add about this fascinating topic of sinus migraine and this idea, this theory that is being put forth before we go today?
Yes, there was one other aspect of this, and this is where do we go from here? Okay, so we're very engaged in trying to do the research that would help validate this theory. And so there's a number of ways we're approaching it. One is that we're trying to learn more about the natural history of this symptom or these symptoms relative to headache. And so we are about to launch a patient registry, which will actually follow people through their experience and over time of the comings and goings of these symptoms, but also response to medications and things like that. And you can learn more about that through the Association of Migraine Disorders, which is our nonprofit organization. We'd love to have people who are fascinated by this disease and want to participate in understanding it more, join that. In addition, though, we are been working with a group at Duke to develop a screening tool so that just like you would have the migraine ID, this would be a series of very short series of questions that would help, we hope, identify for clinicians those people who have this sinus form of migraine. And we're working also to understand the pathophysiology of this disease better through other studies. And then finally, we're trying to track treatments so that we can help sort out what are the best treatment plans. So we are doing we're active in a number of ways in trying to advance the science forward.
Wow. Okay. Well, thank you so much, Dr. Godley. This was a super interesting episode. I bet so many people were sitting there, either they know someone who they think that fits the description, or they think they fit the description themselves. So I think it's interesting. We do want to remind people that it is not an official diagnosis at this time, but it is definitely so thought-provoking, and I really wanted to bring Dr. Godley on to discuss it. So thank you, Dr. Godley, for being here. And thank you everyone else for joining us on this week's episode. Please join us again next week for the weekly webcast and podcast of the National Headache Foundation. Bye-bye, everyone.